esteemed members of the Pharmaceutical Society of Kenya, good evening. Welcome to today's session. If you can hear me, kindly send a message on the chat. Just let us know which branch you're joining us from. Good evening, Dr. Shah. All right, thank you, Dr. Faith Ndeto from Nairobi. Welcome, everyone. Dr. Patel from Yaya Chemists, Karibu. Dr. Joseph Maina, Karibu. Dr. Daniel from Malindi Pharma Plus, Karibu. Dr. Shital from North Rift, Karibu. Dr. Joseph from Nairobi. Dr. Walter from South Nyanza branch, Karibuni. If you are joining us, please let us know which branch you're joining us from. Dr. Alpesh from Pramuk Chemist in Webuye, Karibu. Dr. Kennedy from South Rift, welcome, welcome. All right, thank you so much for your responses. Dr. Ndegwa from Central Rift, Dr. Shelan from North Rift, Karibuni sana. Dr. Onchoke from Mungoma, Dr. Sawe from North Rift, Karibuni sana. Meanwhile, as we wait for our colleagues to join, for those who have not subscribed on the PPB portal, kindly do so. The event is now available on the PPB portal. And here's the keyword. Just search for the word gender and you'll be able to see the event. Dr. Wilson Kialo from Lower Eastern, Karibu. Dr. Joan from Nairobi. Dr. Kongo from Nairobi, Karibuni sana. Dr. Silika from Kiambu County, Karibuni. If you've not subscribed on the PPB portal, just search for the event keyword gender and you'll be able to get this event. All right, thank you so much for joining us. So we'll just get started. For the groups you're in, kindly remind remind our other members to also join this webinar. So welcome to today's webinar. This webinar is on gender mainstreaming in family planning. And this session is going to be covered by Dr. Michael Mungoma and Monica. Dr. Michael Mungoma is the Dean MKU School of Pharmacy and the chairperson for the Pharmaceutical Society of Kenya Education Committee. And Monica Nthumbi is the Senior Reproductive Health Manager at Population Services Kenya. And this session is being supported by inSupply. And first, I'd like to take you through a few ground rules. First, it is to thank you for participating in this session. And to remind you that this session is a webinar, and you'll be muted during the entire course of this session. So if you have any questions, kindly use the Q&A tab, which is at the bottom of your window, and the questions are going to be responded to by the presenters at the end of the session. So once again, if you have not subscribed on the PPB portal, kindly do so. The keyword is gender. Kindly subscribe early so that you can get your CPD points. For the agenda of this session, we'll first have pre-tests that will be done by Dr. Johnston Anyona. Then after that, we'll have a session by Dr. Michael Mungoma on gender mainstreaming in family planning. Then after that, we'll have a presentation by Monica Nthumbi, which will be on male involvement in family planning. Then thereafter, we'll have a post-test and then a Q&A session. So at this point, I'd like to welcome Dr. Johnston Anyona, who will take us through the pre-tests. Dr. Johnson?
Great. Thank you very much, Dr. Hezron. Good evening, colleagues. A warm welcome to our webinar today on this important topic that is aimed at unlocking some of the barriers in access to family planning. So we'll kick off with a brief knowledge check. So I'll be sharing my screen shortly. Let's confirm that you can see.
Yes, we can see.
Good. So please dial into menti.com. Menti is MENTI.com, and the code is at the top of the screen. I hope you can see it. As well, you can also paste the code 84241719. You should see a like button. Please press it so that we can get a tally of the participants who've taken part in the pre-test. For those just joining, we are doing a quick knowledge check on the topic for today. And we're doing it on menti.com. Menti is MENTI.com. And once you're in, you will see a window asking you to put in a code. The code is at the top of the screen. When you join, please press the like button so that we can register your attendance. Okay, let's kick off the Menti. So the first question, the concept and strategy aimed at integrating gender perspectives into all aspects of policies, programs, and projects refers to. Thank you. Can see majority have selected gender mainstreaming. We'll see if that is correct. So the next one, name one strategy that can help overcome gender barriers in family planning. Name one strategy that can help overcome gender barriers in family planning. Great, thank you for your responses. I can see male involvement, public education, sensitization, communication, proper training. Keep them coming. Male participation is really coming out strongly. Male engagement, awareness and education, couple counseling. Thank you. Next question. Which of the following is not a strategy for promoting male engagement in family planning? Which of the following is not a strategy for promoting male engagement in family planning? Great, thank you. Everyone picked excluding men from discussions on FP. We'll see. Next one. Which of the following is not an example of a gender barrier in family planning? Which one is not an example of a gender barrier in family planning? Okay. You can see many people have selected cultural norms that encourage joint decision-making between partners. Okay. Next question. In many societies, men often hold greater control over financial resources, affecting women's ability to access FP services. True or false? Excellent. That is the last pre-test question. Thank you all for participating in this quiz. And I pray that we all stay active and engaged throughout this very exciting session that we have lined up today. Back to you, Hezron.
Right. Thank you so much. Thanks so much, Dr. Johnson, for taking us through that. So at this point, I'd like to welcome our first presenter, Dr. Michael Mungoma, who's the Dean, MKU School of Pharmacy, and the chairperson for the Education Committee at the Pharmaceutical Society of Kenya. So, Dr. Mungoma.
Thank you very much, Hezron, and thank you, Dr. Johnson and inSupply for supporting this and for the introduction. My name is Dr. Michael Mungoma. Good evening, everyone. Good evening, those that are coming in for the first time. This is part of the many CMEs that we have to upskill pharmacists to provide good care of their clients and patients out there, especially in community pharmacies. We've been having a series of webinars around reproductive health and family planning. And today we want to talk about gender mainstreaming in family planning. So I'll just go straight to my presentation. Today we want to talk briefly about FP and gender mainstreaming by pharmacists, how that can contribute to improved development outcomes at family and community level. Again, highlight male involvement, and my colleague there, Monica, will come in just to share some real-life experiences. And then to be able to promote the need for increased investment in family planning services in community pharmacies. So gender mainstreaming, that's the sort of the main two words here. So just by definition, this is a strategy towards realizing gender equality. It involves integration, gender perspective into the preparation, design, implementation, monitoring, and evaluation of policies, regulatory measures, and spending programs with a view of promoting equality between women and men and combating discrimination. So this definition looks like it's something that happens in a very high level. No, we need to look at it at the level where you work. You know, if you work in a community pharmacy, you work in a hospital pharmacy, you work in an office where you're a manager or somebody that is involved in policy, it all applies. So there's so many barriers. There's so many barriers that are there to stop effective access to FP services, especially in community pharmacies. One, social-cultural norms. We know how societies are organized, and some people in the society can have very stringent ways of looking at things, traditional norms, and especially in our setting where there's male domination, especially around reproductive decisions. So women can face a lot of pressure from their families or communities to have more children, including when they need to start having the children and so on. And this can limit their access to family planning services. Second is lack of autonomy. women's ability to access family planning can be hindered by their lack of decision-making power, especially when the power is now shifted elsewhere to someone else, or maybe another authority or something. Limited education. Education is still a concern, especially in rural settings or low-income areas. So you'll find women with lower levels of education there, and that can impact even on how they access contraceptive methods or think around family planning options. Economic barriers. Cost of living is something that could also affect and contribute towards the barriers around access to FP services. Geographical accessibility. There could be places where health facilities, including pharmacies, are far away. It could just be that it is a rural setting where even roads are not well built, or in places where there's even interaction between human beings and wildlife that can decrease accessibility to FP services. Stigma and discrimination, especially those that are seeking FP services and are considered to be outside marriage. Again, these are social norms, and they would face stigma or some form of discrimination. Healthcare provider attitudes. I must say that unfortunately, again, you might find people who are qualified in the healthcare space, but still hold certain biases based on their cultures, based on their religions, based on their background. And this can really affect women who are seeking these services. Some that can even lead to disrespectful events. So legal and policy barriers being one of those ones. Restrictive laws and policies that can limit access in certain countries, where if you're not married, then you have no business looking for family planning services. So what are some of the importances of gender mainstreaming? One, we're looking at it as a human right. And of course, equality comes in again. This provides a platform where both men and women can have equal access to the control of family planning. Remember, family planning doesn't necessarily mean stopping pregnancy. It just means that people can better plan and space out their children. So it is an economic issue and a planning issue. With equality and human rights, again, so these aligns with principles of gender equality, human rights as individuals, and as individuals should have the freedom to make informed choices about their reproductive health. Empowerment, by integrating a gender perspective into all these programs, services, as well as your workspace, men and women can be empowered to make decisions around reproductive health. This is based again on their own preferences, needs, circumstances at the time, and even as some of these things keep changing, because the needs as well as their preferences can change over time. This can be informed by very many things, well, how they respond to the contraceptives, maybe the cost of the contraceptives, the convenience, and so on. Men and women need to get involved. The other is health and well-being. So again, this takes account gender differences and inequalities that can improve the quality of family planning services. We all know that men and women have different needs when it comes to health, as well as they can be predisposed to certain risks. So addressing these differences ensures that both men and women can receive appropriate and effective care. Again, the other importance when it comes to gender mainstreaming is reducing health risks. Gender-specific health risks related to family planning, such as maternal mortality and unsafe abortions, need to be looked at. This is also another area that pharmacies need to get into. PSK is looking into that to see how this can also become a discussion post-abortion care. Women's health and well-being can be compromised when they lack access to safe and effective family planning methods. Population health. Good family planning services contribute towards good populations, good societies. Women have access to these services. They can space their pregnancies, which can lead to healthier outcomes, both for the mothers, children, and also for the fathers, because when we talk about healthier outcomes, this has also an economic connection. If women are given the power to contribute towards the spacing decisions, it also means that men get involved in the effects of that. If they want 3 children, then they can also start planning for school fees and healthcare, and they themselves. Socioeconomic development, individuals, especially women, have control of their reproductive choices. So this can impact positively on their education. They can plan on when to go back to school, how far they want to study, employment opportunities. Again, economic participation for both men and women, because sometimes with pregnancies that can limit, in certain cases, how income flows in the house. And this contributes to an overall socioeconomic development. Then social norms and stereotypes. Gender mainstreaming challenges harmful gender stereotypes and norms that might perpetuate unequal power dynamics in family planning decisions. Yeah? So it sort of looks at equity in the family. The other importance there is policy effectiveness. So these can also be incorporated in policies and programs. That improves efficiency and effectiveness of some of these programs. Looking at very specific needs of different gender groups increases the likelihood of successful outcomes. The other thing that comes with gender mainstreaming that is so important is data collection and analysis. With good designs, even if you're in a community pharmacy and you're collecting information and every now and then you're able to analyze, the data can be, aggregated in a way that can provide a very clear understanding of how people are accessing commodities, people are making inquiries, or who is buying on behalf of who, and how that impacts on different gender groups. So data-driven approach helps identify gaps and tailor interventions accordingly. It could be that it can influence how you design your pharmacy, or how you maybe adjust or make changes in the clinics where you work. You could be working in a hospital. Then there's social justice. Gender mainstreaming aligns with the broader goals of social justice and inclusivity, that men and women need to be included in the discussions and the choices that are being made around reproductive health and access to family planning services. And again, this, as has been mentioned there, seeks to address systemic gender inequalities, which have been reported to limit women's and men's access to family planning services, resources, and information. So how do we implement this in community pharmacies while providing family planning services? One is what we're doing right now, it's training and sensitization. And this is not only limited to maybe pharmacists attending these webinars, but it also extends to transmitting this information to other workers in the pharmacy. You could be having other assistants and so on. They need to be trained and sensitized so that they are aware. Yeah. And this just improves their capacity to recognize and address diverse needs and preferences. So looking at what constitutes discrimination, what constitutes discriminatory behavior or disrespectful communication around family planning. Gender-sensitive communication, very, very important, connected to the sensitization. So it is developing gender-responsive informational materials, about the different methods, their benefits and potential side effects, so that it's gender-sensitive, ensuring that this communication is inclusive, respectful, free from gender stereotypes, or even free from, it could be religious biases, it could be certain cultural or traditional biases that touch on gender. Client-centered approach, being able to customize the counseling to address specific needs and concerns of each individual, regardless of gender. So it could be even, is it somebody trying to seek for family planning services immediately after pregnancy? Maybe they need information, not commodities. It could be people who are planning maybe to travel, or people who are planning to engage in certain activities. It could be going back to school, and they need something that is tailored for them. Diverse family planning methods, stocking a variety of family planning methods to cater to different preferences and needs is quite important. Pharmacies should not have limited variety. Most of the time, you'll find people just saying, no, we want to keep emergency contraceptive pills because that is what moves. However, if you incorporate some of the principles and some of the proposals we made, including counseling, effective counseling, you'll be very surprised that people were just waiting to hear about those options, get clarity about some of those options, and know that these are available in your facility. Providing information about advantages and disadvantages of each method also improves decision-making. Privacy and confidentiality. This is important. How you design your pharmacy, creating a comfortable, private environment where people can discuss family planning choices confidentially, and creating again a rapport that improves or creates trust between you and your client, you and your patient. Inclusivity and accessibility, ensuring that the pharmacy staff treat all clients equally and respectfully, regardless of their gender identity or expression. So this is important because we're now acknowledging the fact that there's an increase in the diversity when it comes to gender identity, including LGBTQ. And this is important when they come to your pharmacy, that you're able to still treat them equally and respectfully, regardless of how they look or how they identify themselves or express themselves. Consider accessibility for individuals with diverse gender identities. And now, importantly, again, engaging men. Men sometimes are identified as people who do not want to open up around reproductive health issues, around family planning service access. So encouraging men to participate in these discussions and decisions, providing information how men can support their partners can be very useful. Promoting gender equity, that is providing information about the importance of shared responsibility for family planning and contraception between partners, can encourage and increase useful engagement, useful application of these methods, and supporting each partner with the method that they decide to use or choose. Challenge norms that place the burden of contraception solely on women, so that men can also know that they are contributors towards successful family planning. I will just allow Hezron to share a video here. I'll stop sharing and then I'll come back. Hezron?
Okay, just a moment. I'm putting it up.
Investing in family planning can accelerate achievement of the Sustainable Development Goals by bringing transformational benefits to women, families, communities, and is one of the most vital health and development intervention. Male involvement has been identified by the government as a high-impact intervention for increasing family planning uptake. Married women in many parts of Kenya must seek the approval of their male partners before seeking family planning services. The male partners often show open resistance when they are inadequately informed of the benefits.
If you engage males in family planning, one of the benefits of engaging male in family planning is that they will be able to support their spouses or their wives to attend clinic, and that allows the mothers or the women to choose a method of their choice. Without male engagement, women will come and pick methods that are not suitable for them, especially injectables, because it is easily to be concealed, and therefore if they are allowed their partners or their spouses to come and choose, then they will be able to pick any method, especially even the long-term methods where some of them needs the support of their spouse. But since this program of involving or engaging men, we have seen a significant improvement of reproductive health indicators as KDHS showed the other day.
According to the KDHS report, Kenya has realized an increase in the use of modern contraceptive methods at national level from 53% in 2014 to 57% in 2022. In Narok County, the use of contraceptive methods increased from 38% in 2014 to 52% in 2022.
Through male engagement, the men will be able to allocate even resources for their spouses to access these reproductive health services, family planning being one of them. And number two, because of public participation, where they actually contribute to community as far as family planning is concerned, especially budgeting and allocation of resources by the county government.
The program identifies male champions from village elders and religious leaders who engage men in meeting points and household level, facilitating them to make informed child-specific decisions as community culture custodians.
Ni nini mzuri kwa mtu akiingia katika family planning? Kwa sababu watu wetu hapo mbeleni hawakuwa wanapata hii elimu, lakini vile sasa wamekuja kujua maana ya kuwa na family planning, ama kuwa na familia, upate nafasi watoto wakue mbali wakati wa kuzaa, inafanya wafanya kazi ile ambayo inatakikana. Watasoma mzuri, watakula mzuri, na pia watafaa mzuri.
Tumepata kwamba numbers of family planning zimekuwa juu, na we do encourage them wakuja na mabwana zao, ndio vile pia tuweze kupatia health education, na mzee pia aweze kubenefit, ndio aweze kubenefit wazee wengine kule nyumbani akiwapelekea ujumbe.
In many parts of Kenya, culturally, men wield immense power in controlling important decisions at family and community level, including reproductive health.
Kulingana na family planning ni jambo la maana. Hivyo ningependa kuwashauri wamama ambao hawakuweza kuelimishwa jinsi ya kupata family planning, wapate elimu na wapate pia family planning, kwa sababu sisi kama jamii ya Sirikwa tumeona family planning ni jambo la maana sana. Serikali nataka kuambia hawa ya 40 30 waingie hii mafunzo, kwa ajili nimeona ni mzuri sana. Iko vitu ambaye tumefundishwa hatujaijua, hata mama anaweza kuwa na kondom yake, hata ya wazee. Nimefurahia sana kwa wazee kukuja
hii mafunzo ambao tulikuwa tunapata through hawa CHFs ambao wanatuelimisha, na nikapata hii elimu ambayo sasa hata sana huwa tunatumia condoms ili ndio tuweze watoto watimishe ile miaka ambayo tunasema anyonye mwaka 2 na apate nguvu ya kunyanya maziwa ya mama yake.
Let's mainstream male engagement as a high-impact practice for increasing family planning uptake. Together, we can build a healthier future for all.
Thank you, Ezron, for that video. And it's very, very informative, and it's very powerful that involving men in reproductive health services and decisions can really make a difference. So I'll just move on with the presentation. And part of the implementation of gender mainstreaming in community pharmacies includes referral networks, establishing partnerships with local health centers, clinics, organizations. People need to know what hospitals are there that specialize in gender-sensitive family planning services, where referrals can be made, especially if clients come to your pharmacy and maybe they feel too shy to open up or discuss beyond maybe the method they came for. So it's important to know where you'd be able to refer them so that they can get more comprehensive care if needed. Data collection and analysis, again, at the pharmacy level is important. It just provides your ability to make certain decisions, even forecasting, and ensuring that you have a sufficient supply of your commodities. Feedback and continuous improvement, getting feedback from clients. You need to find a way of doing that, whether it's, again, creating a very good rapport where they can come and talk to you verbally, or maybe it's use of technology if you have contacts of clients, doing follow-ups just to ensure if they have gotten, they have started a method. It could be an injectable contraceptive like DMPA-SC, and maybe a week later, you're able to call them or text them, or you have a platform. It could be a social media platform where they can access you privately to just share what's happening. Regularly reviewing, updating training materials and practices to stay current is important. Community engagement, engaging community leaders, women's groups, and men's groups to promote awareness. So it's important that even as you're working in your pharmacy, you have a CSR component at whatever level, where you could be belonging to a community, you could be belonging to a certain group. You could be going there in the evening or something, or at the weekends, and you're able to engage these people and talk about how gender mainstreaming can improve overall health as regards family planning. Working together with local organizations to conduct workshops, seminars, and having awareness campaigns on gender and family planning. And then measurement and reporting, So it's important as you're carrying out these activities to measure the impact of what you're doing and include gender considerations as you report. So gender mainstreaming and self-care. Self-care is we have recently just gotten the guidelines out. We're waiting for the official launch, but it's important to see how this is connected. Gender mainstreaming, self-care, and family planning are related in that they both aim to promote equitable and empowered access to family planning services while addressing and recognizing the unique needs, preferences, and challenges that people can face. Yeah, so the role of pharmacists when it comes to connecting the two, one is equity and inclusion. So we're saying here that it is being able to consider and address the different needs, the realities of women and men in family planning programs, eliminating gender-based disparities, ensuring that everyone has equal access. Self-care, on the other hand, recognizes the importance of providing individuals with tools and knowledge to manage their reproductive health needs. With tools, we also mean methods. Tools means information. It could be job aids without facing barriers related to their gender. Empowerment, both gender mainstreaming and self-care aim to empower individuals to make informed decisions about their reproductive health. Self-care, again, empowers people by enabling them to take control of their reproductive health through self-administered methods. It could be pills, it could be self-injectable contraceptives, it could be barrier methods for both men and women, whether it is male or female condoms. Then individualized approach for both concepts, again, recognize the importance of tailoring family planning services to individual needs. Self-care, again, reiterates the fact that diverse preferences for managing the reproductive health and should have the autonomy to choose methods that best suit them in their circumstances. It could be cost, it could be how they're living, it could be partner needs, and so on. Shared responsibility. So gender mainstreaming, again, encourages shared responsibility for family planning decisions, whereas self-care promotes shared responsibility by providing individuals with more options for contraception that they can manage themselves, so that there are options both for men and women or both partners. Again, reducing barriers. Both gender mainstreaming and self-care have a focus on reducing barriers to accessing FP services. This could be socio-cultural, economic, and self-care addresses these barriers such as lack of access to healthcare facilities by providing methods that individuals can use at their convenience. So again, here it's empowering. With self-care, it's aimed at empowering the client, empowering whoever is using these methods. And remember, when you talk about the family planning services, it also means that you provide information even as to where people can seek other specialized services or how they could recognize and address side effects of medicine. So it could include providing information so that people don't sort of panic when they start using a certain method, or they become unsure because they didn't actually follow instructions while you are talking to them, and they're able to come back. Customized information. Gender mainstreaming calls for providing information that is relevant to the gender-specific needs of individuals. And self-care also involves providing clear, comprehensive information about self-administered methods. And this still reiterates the point that individuals make informed choices around methods and around themselves, so that there's a shared responsibility. Cultural sensitivity, the diversity in culture around gender identities and practices. So gender mainstreaming encourages an understanding of local gender dynamics and cultural norms. Depends on your setting. Urban setting, rural settings will have different cultures, and therefore sensitivities around that become very important. Self-care respects individuals' preferences and beliefs regarding their reproductive health. So some of the important highlights just to share as regards to gender mainstreaming and self-care. One, we have this training package that was approved in 2020, where pharmacies and pharmaceutical technologies have been trained and continue being trained in provision of family planning services, including injectable contraceptive, DMPA-AC and DMPA-IM, and that the curriculum also integrates other components, including HIV, STIs, and other related services. And then the self-care guidelines 2023, which were completed. These are yet to be launched, but we'll be disseminating that in upcoming webinars and events, hopefully the World Pharmacist Day in September or World Pharmacist Week. Development of training manual for reproductive health, self-care guidelines, that is also ongoing and yet to be completed. So those are just some of the references that you can look at your own free time. And thank you very much for listening to me. I'll pass this back to Hezron.
Right. Thank you so much, Dr. Mungoma, for taking us through that insightful presentation on gender mainstreaming in family planning. So next, we're going to have our next speaker, Monica Nthumbi from Population Services Kenya, who will be taking us through the male involvement in family planning. Monica, you can hear me?
Yes, I can hear you very clearly. Good evening.
Good evening. Welcome.
Yeah, thank you so much. I take this chance to really congratulate you people, the pharmacists. This is a great thing you're doing. It's my first time I'm participating in this, maybe by the fact that we were sharing some information on how we are doing programming. So as pharmacists, this is a great thing you're doing. I hope I can borrow it and share with my colleagues who are the nurses. That said, I work for Population Services Kenya, and I'm going to be presenting to you the practicality or the practical of how we work, especially how we involve male in the family planning. And just before we go to the first slide, I would like to say most of the counties that we cover are what we call the arid and arid counties. And I would like to list them because I've seen most of the pharmacists who are joining us from the counties where we are working. At the lakeside, we have and that is a reproductive health program, not necessarily any other programs. We're working in Homa Bay and Migori at the lakeside. In the North Rift, we work in West Pokot, Elgeyo Marakwet, and Baringo. Upper Eastern, we are in Samburu, Marsabit, and Isiolo. Northeastern, we're in Mandera, Wajir, and Garissa. While in what we call Greater Nairobi in our programming, that is around Nairobi, we're in Nairobi, Narok, Kajiado, and now at the coast, we are at Kilifi, Kwale, and Mombasa. We just recently pulled out of Lamu. We were also in Lamu. So generally, this presentation is covering experiences from those areas. And as you can see, those are areas which are really, I don't know how to put it, a very strong cultural and gender, let me say masculinity, especially, wow, County 001, I can see you. Yeah, masculinity where people, and also maybe what we call harmful traditional practices, they are very rich in their culture. So when we are talking about gender, when we are talking about family planning and male involvement, these are counties which have really given us experience. I forgot to say in the Upper Eastern, we also have Samburu, Marsabit, and Isiolo. So we can go to the next slide. Next slide. So generally, I just wanted to give a small background. I'm aware that we all know this, but it's always good to remind ourselves why we are talking about this. and just give ourselves that backup that we really know the documents that we're also referring to. We know we have had a lot of commitments. Kenya is one of the countries which has been signing most of the commitments way from way back in the 1960s. And now we have the FP 2030. We even have the FP 2020. And now we are saying in the commitments and several other documents, we have identified that men engagement is a high impact practice for addressing family planning and the unmet need. I'm sure everybody in this meeting knows the unmet need for family planning in our country is at 14% as at now. And so we ask ourselves, why is it important in Kenya? And I think as Daktari has said earlier, you realize that Kenya is a purely almost 90-something% patriarchal society, where men and masculinity are the ones which lead the family. They are the ones who control resources. They are the decision makers. And of course, definitely they are the community decision makers and also the household aides. So from this end, especially from the programming end, we do what we call co-creation using what we call a human-centered design process. And this human-centered design process, you go into the communities, you co-create with them, and you come up with their own solutions. And because I've had so much of community pharmacy community, we are saying this because we use the existing structures, especially the community health strategy, which is everywhere in this country. So we realized that 70% of the women during our co-creation say that men are the barrier to their family planning. Men generally. And so those are now how they are unpackaged. It depends from region to region, how they are unpackaged, how men are now the barrier to the family planning. And now the presentation is a bit blurred, sorry. You could make it a little bit more clear than this for the viewers. It's still blurred unless it's my computer. I'm sure the viewers would like to interact. I'm sure the viewers would like to interact with it. Sorry, it's all right. So even as he comes back, I was saying that women generally, 70% of the women, thank you, it's better now, it's excellent. Women identified men per se as the barriers to their access to family planning. Of course, most of them, they cited from region to region and person to person, they cited different things, like most of it is the support issue, the permissions, the facilitation like the bus fares, Daktari mentioned the distances, the facilitation, access. We know when you talk about access, it has all those dynamics of affordability, the distances, even having who will take care of the children when the woman goes to take the family planning. And so most of those places you found most of the women were combining this family planning with other things they were maybe going to do in the market or the days that they are around in the marketplaces. And most times you really have the missed opportunity there because maybe the time you want to get the family planning arrives before the time for your next visit. And there you have the missed opportunities and unplanned pregnancies. And so Daktari also mentioned about issue of security from wild animals. The places I mentioned, you see the West Pokots, the Manderas, the Wajias. Those are places which are wild animals even hovering around. Don't tell me also in Wajia, I know in Ongata Rongai we also have lions, but yeah, we are talking about the wild animals like in the Samburu parks, in Narok, in the likes of Kajiado. And so they also need this security when they are going and to be escorted and so that they can access this. And so they listen. Men also alluded during this because during co-creation, as you can see in this photo, we also include men sessions so that we can hear their insights. But they also gave us this idea that they listen to fellow men. So we also got this idea that when we are doing programming, we have to get the gatekeepers who are also male, village elders, cultural leaders, local chiefs, the warriors, the people who sit around with them when they're doing declarations under the trees in Samburu, and also the sheikhs. You look at our distribution, we're also in the northeastern where there's a lot of religion as part of the cultural barriers. So we also talk to the sheikhs and we use a lot of sheikhs in programming for family planning in Wajir, Mandera, and Garissa, part of Marsabit as well, and it is really doing well. I'm sure maybe another day we'll talk about the religious the religious aspect of family planning and how we are using religious leaders to improve this. And so men from our targeted areas also love livestock. I'm sure you can still remember the kind of counties I've mentioned. So you start looking for what do men value? Where can you hook their emotions? Where can you really get them? These people will go to the watering points. They like sitting under the trees, under the cultural. They like to discuss their issues. And that is the place where you go. So we started looking for interventions which follow men where they are. So that, because it's very rare, and you'll find in the next slide, maybe you can go next, to find men having a gathering naturally. So you just you follow them where they are. So next slide. So the key activities which we've been doing in our programming, in our major two programs, DESIP, the one you have just seen, and the one I lead called Accelerate, is mapping the culturally respectful and trustworthy gatekeepers, definitely through the community health strategy. I just mentioned this. And from the insights that we gather from the people, we use them then to develop very social behavior change communication strategy, which is targeted and also targeted at areas. Like, for instance, there is a section we do what we call a day in life. A day in life, you walk through a journey of the woman from morning to evening, or even the man from morning to evening. So you get to know what are the times when I want to catch this man, maybe listens to radio, what are the times they watch television, what are the times they do this and this. So those are the times like you bring an advert, those are the times like you take them to the local radio so that they can be heard, so that you can air something. Then you also know what are the times they go maybe to congregated some centers or somewhere for some reason. Then you time them there and you get the messages there. Then, of course, training. In our trainings, we've aimed at the male champions. I think you also saw the guy from Narok in the video speaking. That is a guy we use also for, he's the ASRH champion and was the reproductive health coordinator for Narok. I'm sure some people here also know him. So we make sure that we also select men purposefully, the champions, and also the male CHVs. We didn't talk about the male CHVs here, and also the champions, so that they also go out and also they become champions. In Nairobi, we had a program which was very particular. We were saying, we men care. We men ourselves, we care. So you get to identify them and you make sure that they're also involved so that they become champions. And because from the background, we have seen that men listen to fellow men, so that we use them in family planning. And also role modeling, and also, of course, mapping, and also those referrals. Then men champions were also trained in GBV. And I think Dr. Mungoma mentioned something very important of the human-based approach and the lenses that we wear, which are, when you are wearing a gender lens in programming, you cannot ignore GBV. In our country, we see every day in the news and everywhere about GBV, and family planning and GBV are quite intertwined, or if you wish, SRHR, because you can see the nature of things which happen during GBV. Most of them, let's talk about rape and all that. What is the outcome of rape? Number one, they are pregnancies, they are STIs, they are all that, so they are quite intertwined. So we also took them through a component of gender-based violence and basic human rights during this training, so that as they speak to the men, they intertwine them, and they also take them through and show them the intertwined nature and how they should also come out through. We also have a program on boys. I forgot to maybe include it here, where we nurture the young boys. And we tell them to come out as champions, because we have realized also interventions which aim to look at boys when they are still young, or people generally when they are young. It's easier to nurture them rather than coming to transform them through social behavior change and communication. We had a very strong campaign, SBCC, which is now still going on. If you see on your right, this guy here in a green t-shirt, there are some messages there. That is a promise he's making. We had the Hahad Yangu. So this is a promise you make. So the young boys were promising, I will protect my sister. This man here most likely is a village elder. Is also promising, I will protect our children against FGM. I will protect them against this and that. And we also get the healthcare worker saying that I'll make sure that I give family planning and all that. And they were all intertwined with GBV. So Dr. Mungoma also talked about development of materials, and I was really enjoying his talk because it was just wrapping up what I was coming to say, the real examples. You can see like the flip chart that guy is holding. And in PS Kenya, we are known for developing communication materials. We develop information materials which are derived from the insights those we got from the men. So they are very particular. Sometimes we even involve them in sketching up and coming up with the information themselves so that within that particular community, if it is Kajiado, whatever they are brought out, if it is for the youth, we sketch to the youth of Kajiado. If it is for the Moran in Samburu, we sketch to the Moran of Samburu. If it is for the young man in Garissa, we sketch with him and we put a young man there wearing a kanju, because otherwise if you put somebody who is not culturally accepted, they again will run away. So it's like beseeching men, just begging them and looking for things which are culturally acceptable, and the way just to massage their egos. We all know men want to be massaged and to be brought closer. So we've been looking for these ways. We get materials which are very specific to men, and they use to the other men, and they start getting interested. We've also engaged couples and the family. I think the last slide for Dr. Mungoma was talking about family. And I think until we also aim at couples and realizing that these people are partners, then we are not going anywhere. So we look at couples, we have also counseling, and we've also made some CHV champions, starting with themselves because they are members of the community, and also getting to reach the other people, also using the county teams because we work through the government of the counties. Then we cannot ignore the thing called men only or male only. These forums are there, they exist, and these are like the cultural events. You'll find like in the North Rift mostly, you have events where a woman, and also in Northeastern, right? There are events where you cannot get a woman in there. So you look for those events like the declarations I talked about earlier, male dialogue days, action days, those cattle markets, cattle watering points, the trees of men where they go to make some important decisions, or even just to listen to what is going on. Those areas you listen to the wind and know what's going on here. Then the religious leader sessions and all that. So we've also aimed at this. And of course, we also use the other men to go there. Like now in the cultural, in the mosques, we use the sheikhs. In the watering areas, we use the elders. So we identify people who used to reach the others, so that we are doing a lot in our programming. The other thing is engaging men as FP users and facilitators as well. We've had, I will say that vasectomy has not really been taken, but you saw them talking about condom in the video. They are taking condom, it's a low-hanging fruit, and of course it's a beginning point. We start, a journey of 1,000 miles starts with a single step. So we are engaging them, and you find 1, 2, 3 here, there, but we are getting there. We can go to the next one. Let's go to the next slide. Oh, good. So what are the lessons we've learned during our programming at Population Services Kenya, and especially from those areas that we do? Co-creating, and that is the way to go, and especially using the human-centered design, co-creating solutions with the women of reproductive age and our ecosystem, everything around her, not only identifies the real barriers, but also targets driven solutions. Because then everything that you're going to come out with is driven from that woman, from that ecosystem. She'll tell you the time she goes for the water. She'll tell me the time she comes back. She'll tell you the time she watches the TV. She'll tell you all that time. So if you want to target her with information, you know the right time to target this woman. And also the male as well. Then men are not against FP. It is the lack of information. And I think Dr. Mungoma really also mentioned this. They don't have information. And if they get it, I don't think they are getting adequate and right information. So I think also as pharmacists, you can look for ways, because you know there are very many people who come like over the counter and all that, of ways that you can make sure that if a man comes, you can even start by congratulating him and also give him some information, even when he's buying something else. How can you layer this with these other things they come for? And I know men buy condoms a lot over the counter. So can you also remind him that is also family planning, so that he can, you just remind him and show him that this is a way they are also using family planning. So also we give them the right information and why it is important. There's also little or maybe nothing in meaningful involvement of culturally household aids. And they termed this as Madharau. I'm sure most of you understand Kiswahili here. So, you know, men, I talked about ego. And when you look at a man, he wants to be recognized, he wants to be massaged and all that. So there are these deep-seated social norms, and they've been brought up to be, let me use the word begged, quote unquote. So sometimes they just say they feel madara when they're not involved. Most of the programs, you know, they just go target the women go, they see them, and then they come back, just tell you they learned something. So there's also been lack of involvement of men from programming. So now we are deliberately seeing how we are going to involve them. Then we're also identifying and working along with positive socio-cultural systems. Like in the pre-test, I saw a question on this asking whether promotion of the cultural norms, those encourage women and men to work together. So we don't throw everything. I talked about harmful traditional practices, but there are very positive traditional practices in these areas, and which should be encouraged and also just picked and put into programming, because then that becomes a low-hanging fruit and something that translates into a very high impact intervention, because it's already what people are accepting culturally. The other thing is that women of reproductive age in Kenya, and most of them are also the rural areas I've talked about, you realize we're in the border points, we're in very culturally rich areas. They are very diverse. And as I said, they are all surrounded by different environments. So we don't have a one dress fitting everyone. When we go to Kilifi, we design there with the county. When we come to Homa Bay, we design with Akoth. And in fact, we give our prototypes names. We don't have a prototype saying a prototype of Kilifi. No, you find it with a name. Because you remember, I know we are medical people, you remember in medicalization and demedicalization, all that, when we used to call people bed numbers and all these kind of things. So our prototypes have names. If it is Kisumu, we look for the name which is being used now for that young girl or that young boy. The young girl is now Tamara. It's no longer the Monicas and all the whoever they were before. So you go with that culture and where they are now, so that you don't bring a name that is reflecting like an older woman like I am, but you use the Tamara who they have now. So we use very specific, and it is tailored to fit that context particularly, and does not have to fit the next context. Even as close as Isiolo, even some places of Isiolo cannot fit in Marsabit and vice versa, neither Samburu. There's also securing men regular groups is a challenge, and I think you know that. I think majority of us here are men. I observed that, and I was going to say this is very good because we are already having male involvement in discussions of this family planning. That is very good. So securing men in a regular group, as I said earlier, is very hard. So we go, we follow them. We go where they are. We look for their calendars. You know, when are they having their next meeting? Where are they meeting? When is the market day? When is the watering day? When are they doing this? So that we target them and we go where they are, because we need just to follow them. They are very poor in health-seeking behavior, and all that pertains information and everything. Then there's also continuous iteration of messaging. And men are not knowledgeable on RH, as I said earlier there. So you keep giving them information, and when it looks like it wants to bore you, iterate it. You give it the latest version, you give it the latest way. And I'm very happy we are talking of gender mainstreaming also as pharmacists, because that shows we are cognizant of the latest things which are affecting our society. So iteration becomes very important, and then you have an upward movement of achievements. Then myths, of course, and misconceptions. We can't finish this without talking about myths and misconceptions. I remember even the World Contraceptive Day last year's theme was myths and misconceptions. We are in a society which is very rich in the myths and misconceptions, but we are fighting them whichever way we can, and at least step by step. And you realize that most of them go beyond even the family planning. It is the wealth, the number of children you have. Yeah, very political country. It is the number of voters you have. It is the number of strength. It's like the kind of people you command. So it goes beyond this. So it's upon us to work around that and make sure that we show them you can still have your numbers, but just space them 2 years. You can still have your 5 children, space them in 2 years. Before they know it, they'll have only 3 or something. The last one on this one is as compared to women, only a handful of men have been reached. More investment is needed to reach men, and I think that is why we are all talking about gender mainstreaming, at least to make sure that both genders are being reached. So we can go to the next. slide, and I think it is the last one. Let's go to the next. Yeah, we had very soft observations, and we continue to have them. They have even gotten better now. So we now see less women leaving their family planning cards at Mulot, and Mulot was just an example. It's in a part of Narok just before you proceed to Bomet. So there was this practice of women coming to the facility and leaving their card there so that there's no evidence when they go home. But nowadays they are very less, or even some facilities, none of them is leaving the card there. That means they have been able to inform their partners, and now they're getting support. In 2022, we had a number of reduced women showing up with more than one children. We were having women coming with 4 children, 3 children, even handling them, even getting services is hard because these children are angry, they are all crying, they are all needy. But now we are having even women walking in without a single child, or at least with one child. That is a very great observation, which I've observed in our programming as we move on. Then there's a notable shift from injectables to implants. That is the long-acting contraceptives, as we all know. And you know that they give a better couple years of protection. They also give a better planning time and all that. We cannot overemphasize this. I'm sure we are people who understand why we should always skew towards the long-acting contraceptives, because they give a better time and all that. Then men spying. There was a lot of men spying in the beginning, and of course a lot of what would I call it? Yeah, suspicion. They are spying on their women every time. This has decreased, and in fact, most of them now are becoming accompanying their women to the facility. And when they come to the facility, we also encourage them and we give them first priority. Some of the places like Nairobi, we have even clinics where we even take their vitals. We take their blood pressure, their sugar. And some of the reasons why they were not even coming before is the fear of being tested for HIV. Sometimes they tell the wife, if you have been tested, it's our test. So you just try to eliminate things one by one. However, there is still a men resistance to FP uptake, and some men are forced their women to remove. We've seen women, and especially brutally attacked. You see, like the implants are inserted here on the hand. We've seen women whose men have cut them with a knife or a panga. We've received such. We don't like it, but the incidences have reduced, and this is something we can work on, all of us. And right at the right there, you can see the kind of places where we follow men. As I told you, we follow them where they are. We even go there with, with our banners, because we are very determined to make sure that both genders are active in family planning. Thank you so much. Back to you, Dr. Mungoma.
All right. Thank you so much, Monica, for that insightful presentation. I think you've really shown us some really good work that you are doing, going to the grassroots, trying to find where men are and educating them on family planning. Thank you so much for that. So we are almost winding up the session, and I'd like to ask our members, kindly, if you have any questions, this is the time to put them on the chat for both speakers so that they'll be responded in the end of the session. So at this point, I'd like to welcome Dr. Genuine, who will be running a post-test before we get into the Q&A session.
Thanks, Dr. Hezron, and thank you to all the participants who are still with us to this point. We want to see if any learning has happened, and so I'd like us to go back to Menti again. We've had quite exciting presentations from Dr. Mungoma and Monica. And so if you're able to go to Menti, the code is at the top of my screen. The code is 84241719. And Hezron, you can also put it in the chat, please. Once you get in, click on the thumbs up so that we know you're ready to go. We're at 35. Let's get to 50 and then we can begin. Amazing. We're at 50, so we can start. So the first question is the concept and strategy aimed at integrating gender perspectives into all aspects of policies, programs, and projects refers to what? Is it gender symmetry? Is it gender equality, gender fluidity, or gender mainstreaming? Wow, so I can see here a bulk of you are getting the correct answer. So this concept and strategy is gender mainstreaming. Next question is, name one strategy that can help overcome gender barriers in family planning. Dr. Mungoma has mentioned a number. Monica has also mentioned a number, so just share your answers. Male involvement is coming out at the top. Male engagement, men inclusion, male contribution, bringing men on board. Stakeholder involvement. I see patient education. Couple services. I see a response on couple services. Government intervention. Sanitization. I don't know what that means. But I think the overarching idea here is that we need men involved, we need men engaged, we need to do a lot of community sensitization, we need to involve all the key stakeholders to break or overcome any existing gender barriers to access for quality family planning. Just keep the responses coming. And most of you are correct. So we move on to the next question. Which of the following is not a strategy for promoting male engagement in family planning? Which of the following is not a strategy for promoting male engagement in family planning? Is it providing men with information about reproductive health and FP? Is it adding services that are beneficial to men to the FP package? Is it excluding men from discussions about FP to give women more agency? Is it utilizing male peer educators and champions? And I think for this one, almost all of you are getting it correctly. So it is excluding men from discussions about family planning is not a strategy for promoting male engagement. Excellent. Let's move on to the next question. Which of the following is not an example of a gender barrier in family planning? Which of the following is not an example of a gender barrier in family planning? Is it lack of male involvement and support in FP choices? Is it unequal power dynamics between men and women in decision making? Is it cultural norms that encourage joint decision making between partners, or limited access to reproductive health education for women? Which of the following is not an example of a gender barrier? Again, I think here we are also seeing that many of you are getting the correct answer, which is cultural norms that encourage joint decision-making between partners is not a gender barrier. It's good to see that learning has actually happened. And lastly, in many societies, men often hold greater control over financial resources, affecting the women's ability to access family planning services. Is this true or is it false? From the presentation by Monica and also from the presentation by Dr. Mungoma, is this true or is this false? Again, this one is an overarching true answer, and that is the correct answer. So great job, everyone. I think we're satisfied that learning has occurred. And thank you for staying with us to the end, to this far of the webinar. I will hand it back to Hezron. Thank you.
All right. Thank you so much, Dr. Genuine, for facilitating that session. So now we'll be moving to the Q&A session. And so far, I've seen we have one question that is from Dr. Chelimo, who's asking, what happens in cases where men do not use family planning with their wives, but with mpango wa kando? So I don't know, maybe Dr. Mungoma or Monica, if you have any comments on that.
Just repeat again. Sorry.
The question is, what happens in cases where men do not use family planning with their wives, but with mpango wa kando?
Can I go, Dr. Mungoma?
Yes, please.
I think here, without belaboring anything, the bottom line is there is use of family planning. But unfortunately, this is now where you get a typical case of lack of male involvement, because utapata that wife is also using, but now he's not involved. But mpango wa kando is so involved because he most likely does not want to come up with, allow me to say, quote unquote, outgrowers. So I think the bottom line, I'm very happy he's using family planning somewhere. And maybe wherever he's not using, he's only not involved. There's already use. My thoughts.
All right, thank you so much, Monica. We have another question, which is on how best can pharmacists contribute to address the triple threat, new HIV infections, teenage pregnancies, and SGBV?
Yeah, so that's a very important question, and I think what I mentioned earlier is that part of these CMEs is to empower pharmacists. Yeah, and pharmacists need to have self-paced learning attitudes and practices around FP and around SRH, sexual and reproductive health rights, so that they can engage adolescents, because that is one group that is becoming more and more important when it comes to reproductive health. More teenagers are becoming more sexually active early and through to their adult life. And then with the new infections, it is being able to communicate correctly and clearly to clients about barrier methods. And two, importantly, that non-barrier methods of contraceptives do not protect people from HIV and other STIs, so that clients, people out there can be empowered. You know, sometimes it's just a lack of information. It's just a lack of opportunities to engage. Pharmacists can use job aids, can use posters, can use other forms of information, IEC materials, whether it's sticking them in their pharmacies, that can provoke conversations, that can provoke questions from clients as they walk in. So it's for me, I look at it as being empowered, having the tools to be able to communicate and educate, because I think education is the most powerful thing. Back to you.
Doctor, if I can just add one more word. I know we are tuko mashinani, so most of the triple threat is being coordinated through the NCPD. So if you can locate the person who is covering NCPD in your region, they will give you these materials Dr. Mungoma is talking about. And they'll also inform you on the latest, what's going on, what are the things being advocated for. At least as you do all that, you can also stay in tandem with the other people and at least know what's going on. So if you locate the NCPD office, especially the people at counties and sub-county offices, you can be able to get very useful materials on the same, and at least to always know what is next, what is being done. And I think now it's even a country threat. I can't remember the fourth one. Thank you so much.
All right, thank you so much for the responses. We have another question from Dr. Daniel Njuguna, who's asking, says sometimes back there were trials on male daily pills. What's the progress?
I think I don't remember male daily pills. What I remember was there was a clinical trial that was around a male contraceptive, and the male contraceptive was a gel or a cream that was being applied on the skin. I think it was being applied on the shoulder, and the success rate was quite impressive. Beyond that, I really don't know whether that has been registered. I know that the clinical trial was actually done in Kenya at KNH. You can Google and just Google male contraceptive trials in Kenya, and it will provide you that detail. But the male daily pills, I don't know. Monica, do we have male daily pills?
I really wish we do. I've not heard about them yet.
Yeah, okay. Yes, back
All
to
right,
you, Hezron. And
all
yeah.
right, thank you. Maybe we can just pick the last question because of time. There's a question by Dr. Mokwa, who's asking, how do you address the relationship between ectopic pregnancy and family planning?
Well,
Dr. Mungoma,
I'm not sure whether one contributes towards the other. I just know that ectopic pregnancy is an emergency. It's actually an emergency, yeah, surgical emergency, where the pregnancy is in the fallopian tubes. However, I'm not sure what the question means, whether it is proposing or suggesting that there's a relationship between that, but people using family planning methods, we know that the safety around family planning methods are usually quite high when they're used correctly and consistently. Most of them are above 90%, and it should not cause any panic. I think that would be my answer to, or maybe my response rather than my answer, but it could be something else that is being asked there.
Neither, maybe the person asking would maybe expound on the relationship. What I know is a relationship between post-abortion care and maybe ectopic pregnancy, and just because of the exposure, but for family planning, I'm also completely not aware of the relationship between family planning and ectopic pregnancy. Maybe it could also be grouped within the myths and misconceptions, if I'm not wrong.
Yeah, I think that's a very good answer. I think maybe it lies in the misconceptions. So yeah, we could actually take it there in the myths and misconceptions, so that we don't get people advising other people or telling other people that FP is related to ectopic pregnancy.
Thank you so much. Finally, Dr. Mungoma, I think maybe you could respond on this one. There's a question by Dr. Geoffrey Come who's saying, what's the plan of empowering pharmacists, not only to advise on the methods, but also administer? Maybe you can just close with that.
Yes. So just to say, as PSK, we have been training pharmacists on provision of quality family planning services using the approved MOH curricula. I know we haven't trained recently, but that is something that is always on the table. We are still putting together resources. Hopefully, there'll be another cohort being trained at the end of this month, but this is a very specific group. However, moving forward, we are working closely with a few partners to see how this can also be expanded to include other methods, including implants, but this is still at proposal stage. And hopefully by the end of the year, we'll have more pharmacists trained. But at this point, maybe even before we finish, I just want to say that I know we've had a bit of inquiries about availability and access to certain methods. PSK is going to organize a meeting very soon where we'll invite those that are already providing certain methods and those that were trained, so that we can address the issues of supply chain. And just look out for that. If you're interested, you can also send me an email directly so that even as I compile the list of the people that we are going to invite and connect to some of the people that are going to facilitate, we have a good number of people that would want to know where to access. Thank you.
All right. Thank you so much, Dr. Mungoma. And on that point, I think also Dr. Johnson had shared a contact on the chat for those who are looking for a place where they can access supplies for DMPA-SC. So at this point, I'd like to just welcome our speakers again to just give their parting shots, just for maybe 30 seconds to 1 minute. Maybe we could start with Monica.
Yeah, thank you so much. Thank you for the honor of presenting to the pharmacists. And even before I say my parting shot, kindly share my contacts with the doctor who is requesting for my contacts. I'm sure you can access him. And I can only tell you, as pharmacists, kindly let us join in this movement. And it's until we form that critical mass of people that can transform the family planning in our country. And on this forum, I must echo Dr. Dwiga. You know, he's a pharmacist. He's the one heading the family planning programming in Kenya. And so he has led us well, and is at least set as a role model for us pharmacists now. So let us not drop the ball. Let us keep the fire burning. Let us see how much we can achieve during his time. Thank you so much. Good evening.
All right, thank you. Maybe next we can have Dr. Mungoma.
Yeah, no, for me, it's just to continue encouraging everyone who's showed up today and those that were new about this, that continuous professional development is a personal responsibility. Please stay committed to empowering yourself, with knowledge, skills. Look out for new things around FP and other services so that this comprehensive care that is needed at community pharmacies is actually achieved. Keep promoting self-care and taking care of the communities. Otherwise, I'm really thankful for inSupply for the continuous support and also for Dr. Hezron for organizing this very, very well, and Monica for turning up last minute and providing very, very useful information and experience around gender mainstreaming. Thank you.
All right, thank you so much, Dr. Mungoma. Maybe we can have a word from someone from inSupply, Dr. Johnson, Dr. Genuine.
Yeah.
Maybe you could just say something.
Yeah, I would really like to appreciate our speakers, Dr. Mungoma, Monica. That was a very insightful session. I've also learned quite a bit. I've really enjoyed that quote that I saw, that men are not against family planning. Their apprehension emanates from inadequate information on FP. So I hope to my colleagues that by engaging in this conversation, we can take a step towards promoting not just women's rights to reproductive health, but also acknowledging the importance of men as allies in this journey for expanding FP access. So thanks to PSK for hosting this, and also thank you, Hezron, for being an excellent moderator for this session. Thanks and good evening, everyone.
All right, thank you so much for the support inSupply, and for our speakers, Dr. Mungoma, Monica, thank you so much. Briefly, just before we end, I'd like to remind you, kindly subscribe for the event on the PPB portal. The keyword is gender, and you'll be able to find the event. So kindly subscribe early so that you can be sent your CPD points on your email addresses. Another thing to note is PSK is currently doing the advocacy, usually on Thursdays. We usually send various communications on family planning. So watch out for them and also share the information that you learn with your clients and the public. Reminder, the job advertisement for the CEO of the Pharmaceutical Society of Kenya is the deadline has been extended up to 31st of August. So kindly, for those who are interested in the position, please apply. And the other thing to remember is this weekend we're having a nature trail walk at Olulua. So if you're interested, also kindly register for the event. Thank you so much. For more information, there's the inSupply page at inSupply Health. Kindly follow them on LinkedIn, on Twitter. You'll be able to get more information. And for PSK, for Facebook at Pharmaceutical Society of Kenya, on YouTube at Pharmaceutical Society of Kenya, and on Twitter and Instagram at PS of Kenya. Thank you so much for joining us today, and looking forward to seeing you in the next events. Thank you so much, and have a good evening. Thank you.